Good afternoon and welcome to today's podcast. My name is Fraser Cobb. I'm the Executive Director of the American College of Radiation Oncology. And it is my pleasure to introduce the host of today's podcast, Dr. Brian Lally from Penn Medicine and a member of the ACRO Board of Chancellors. Dr. Lally?
Thanks for that introduction, Fraser. Today, I'm really excited because I get to talk with one of my favorite radiation oncologists, Dr. Elizabeth Levick, also known as Betsy. She's going to be telling us today about GammaTile therapy. She currently uses it in her practice out in Cincinnati, Ohio. GT Medical Technology created this innovative treatment option for patients with brain tumors. GammaTile therapy was cleared by the FDA in 2018 for recurrent brain tumors, and in 2020 for newly diagnosed malignant brain tumors of all histologies, including brain mets, high-grade gliomas, and aggressive meningiomas. Betsy, welcome to ACRO Podcast. Would you take a minute to introduce yourself to our listeners?
Thanks, Brian. I'm actually excited to be here. I am a radiation oncologist at OHC in Cincinnati, Ohio, and we are a really big multidisciplinary group with radiation oncologists, medical oncologists, gyn oncologists, breast surgeons, and a BMT transplant program. So we have a really robust program, and we started to focus on GammaTile. Well, once we had a brain tumor group of dedicated physicians, we started to have a brain tumor center at one of the hospitals. And it's interesting, the brain tumor center has neurosurgeons, neuro-oncologists, and radiation oncologists. And this was really vital to get all the cases from our large group in and to be able to offer GammaTile to our patients.
That's great, Betsy. Thanks for telling me that. It's my understanding that GammaTile therapy was created out of a critical unmet need to overcome the limitations of current treatments and to raise the standard of care for patients with brain tumors. Can you tell me a little bit about what was the standard of care and treatment options for patients with brain tumors prior to GammaTile, and how GammaTile is now meeting that unmet need?
I think as radiation oncologists, we all know that surgery absolutely is a mainstay of treatment for brain tumors. Usually, let's talk about the glioblastoma patient, followed by 6 weeks of external radiation, followed by some sort of systemic therapy, followed by tumor treating fields. And what we found is, as we all know, most patients relapse at the tumor bed, but there's also some patients that relapse really quickly. And our options were incredibly limited with these patients. And so GammaTile gave us a new option for these patients. In addition, we're pretty fortunate that we get to offer clinical trials using GammaTile for our patients as well. Brian, I'm old enough to remember doing implants with placing iodine seeds into the cavity and gluing them in, and then using stranded seeds. I know. And it was just not very pretty isodoses that came out. You got cold spots, hot spots, non-conformal plan, and worst of all, you got a lot of radiation necrosis. So GammaTile has changed the playing field with this. We get a lot prettier dose distributions and conformity.
So why should a radiation oncologist recommend GammaTile therapy over other treatment options such as external beam or even proton beam therapy?
First of all, when we go to the OR to put in the GammaTiles, it is amazing to see how little time they add to this surgical procedure. Secondly, once the patients are awake, we know those GammaTiles are giving their radiation off right away. Half the radiation is given in about 10 days. And if you look at 6 weeks, about 95% of the radiation is given. The patients are doing really well with probably equal side effects to just having surgery alone. So it allows you to get their other therapies in, if needed, more quickly. It also offers options that we didn't have before, especially with these patients with relapsed glioblastomas, some of the ones with recurrent meningiomas, and really all sorts of tumors, including brain mets. So it's really quick recovery onto other therapy with very good efficacy.
That's good to know. Betsy, tell me, in your experience, what do you think a good candidate for GammaTile therapy, what that patient looks like?
So initially, when we first started doing them, they were approved for recurrent tumors, and we initially started doing recurrent GBMs. And we still treat patients with operable, resectable, or medical candidates with recurrent GBMs. But obviously now it's for first-line therapies. We can do meningiomas because typically the GammaTiles line the tumor cavity, but you can also line the dural surface if needed. You can line near sinuses. But we have patients that live in the country really far away who can't come in for treatment, where we've talked about different options, including external beam. And because of the ease of the GammaTile, especially with meningioma, they don't want to come in for 5.5 weeks of radiation. So they would pick GammaTile. In addition, we do have a clinical protocol that we can offer patients with metastatic disease, which offers them resection and GammaTile placement versus resection and SRS, and then on to systemic therapy for their brain metastasis. So lots of good patients for GammaTile.
Sounds like a patient I saw yesterday that could probably benefit from that. I want you to help me help our listeners visualize what this looks like, okay? GammaTile is a small collagen tile that's about 2 centimeters by 2 centimeters in size and 4 centimeters thick. It contains 4 radioactive cesium-131 seeds. The collagen tile acts as a carrier to offset the seeds from the surface of the brain, and thereby, reducing some of those concerns that people have with brain brachytherapy, as you were talking about with the necrosis. What's interesting is the radiation treatment begins targeting the tumor cells immediately without having to wait for the incision to heal. Can you explain how GammaTile delivers the target therapeutic dose to the dose of radiation to the tumor bed?
So when you see a GammaTile, it looks like a postage stamp, a white postage stamp, and then there's these 4 tiny embedded seeds that sort of look like mechanical lead pencils. So the radioactivity is within those little seeds. And what happens is we pre-plan to determine how many tiles to actually order. On average, I would say it's between 3 and 6 tiles. And when we're in the OR, what's nice about it is we wet these tiles down and they become very sort of malleable. You can form them right around the tumor cavities, and they stay in place really pretty well with this bumpy side in the brain. So what happens is, you're right, the radiation starts to be given off immediately. The collagen mesh that they're in will dissolve over 3 to 4 months, and that leaves the radiation seeds, which have embedded pretty well, in place. So the seed distribution looks great. We always scan them post-surgery. We scan them at 3 months, and those seeds, for the most part, have not moved. They are embedded. So you subsequently have really nice dose distributions with some conformality and uniform spacing too. So they look really nice, and we're really getting great dosimetric plans post-implant.
I remember this from when I was a resident, how people would be concerned about brain brachytherapy and the reputation. But I understand that the tile carrier mitigates a lot of the safety risk associated with brachytherapy. You have been using GammaTile for several years now, right, Betsy?
That's correct, Brian.
Can you speak to your experience about the safety profile of GammaTile in terms of radiation necrosis, wound healing, and other types of side effects?
Brian, anyone who treats brain disease knows there's a risk of radiation necrosis. Treat enough patients, you're going to get your 10% risk of radiation necrosis. In our experience, it's not a lot different than with GammaTile. What we found is the patients who do undergo GammaTile and who have symptomatic radiation necrosis, they're usually responding quite well to medical management, and we have not had to reoperate on any one of our patients. Other side effects, including, whether it's delayed healing, wound dehiscence, whatever, appear pretty similar to just having surgery alone. So we have not found a lot of side effects that are greater than just doing surgery alone.
Betsy, can you tell me a little bit about the mechanism, how this works? Also, I'm so used to when I do my planning in radiation therapy, looking at the dosimetry and how you dose it. How do you prescribe, how do you dose with GammaTile to make sure that you're getting the coverage you need?
So our usual dose is about 60 gray. So we bring in the pre-plans, and there is a formula you can use to calculate the volume and the size. But when you start doing these, you sort of get a gist of how many tiles to order. And once you're in the OR and you can see the cavity under the on the screens with the operating microscopes, you're able to line the cavities with these tiles. And post-plan, our goal is obviously you no longer have what we would call a GTV. So we look at the tumor cavity, we expand the tumor cavity by 5 millimeters. We sort of cut out that tumor cavity and try to figure out what dose, so how much of that 60 gray are you really getting to the margin where you likely have tumor recurrences. These GammaTiles, since you're applying them directly to the brain, really just penetrate very, very nicely with their dose distribution.
So I know this is a team sport, and we're going to have some discussion at the end about some team sports that we were discussing earlier, but I'm going to hold off on that for now. I'm going to try and stay focused on GammaTile. But given it's like a team sport, and I got news for you, I love working with my neurosurgeons. I've got 4 great ones now that I work with pretty regularly, and I enjoy it immensely, our discussions. But tell me, how do you work with them? How do you identify patients? How do you get them into the OR, complete the cases? And, are you in the OR during the surgery and stuff like that too? Are you placing it or are they?
So Brian, if I see a consult and I think they're either appropriate for GammaTile or clinical protocol, and on the same token, if our neurosurgeons do too. And I have to tell you, I enjoy working with our neurosurgeons who are all oncology fellowship trained as well, equally as much. We pick up the phone, we call each other, and we will both see the patient as quickly as possible. We also have a neuro-oncology tumor board every week where we can review imaging, go through previous radiation if they have it, discuss treatment options. The neuro-oncologist is on the, usually we're doing these remotely now, can be on the phone as well or in person. So we're able to go through all of that and really try to come up with a great treatment plan for the patient. So once we know it's GammaTile, we really can pretty quickly turn these cases around and get the tiles actually ordered. And we have 3 physicians, I think 3 physicians right now who are all capable radiation physicians of doing the GammaTile. So we set up an OR time with, God love our schedulers and the neurosurgeon schedulers, that we would plan to be in the OR. And how it technically works is we've consented the patients, the neurosurgeons have consented the patient. The patient goes to the OR, they do their maximal safe tumor resection, and then they call pathology. We try to get frozen path reviews on all these patients. And we usually are called up when we're waiting on pathology to come to give us an answer. Is this malignant or is it radiation change, especially in recurrent tumor? Sometimes we need a pathology because we haven't gotten a pathology from either their lung or somewhere else. And from there, we're called up and we get the GammaTiles ready. We have to wet them with sterile saline and get all ready. And once we hear from the pathology, I hand those wet tiles off to the neurosurgeons. If any tiles need to be cut, I do the cutting because my physicist would absolutely kill me if they cut through a tile. And I usually hand them off to the neurosurgeon. It's a pretty tight space, them trying to get into a tumor cavity. But on the other hand, I can watch on the screens that those are looking really good. And we decide, do you need a full tile? Do you need a half tile? But, we talk about it during the case. And this literally takes 3 to 5 minutes max. After the tiles are in, I usually get to leave my physicist there and the neurosurgeons close. I sign the authorized user papers and the prescription, and I wait for the post-plant, I wait for the imaging to come back down and see the patient the next day.
That's great to hear. You know, one of the things that drives me nuts these days when I'm in my practice is all those EviCore forms, filling out this, getting authorization. I feel like I spend more time doing peer-to-peers than anything, you know? I know that, you know, this is covered by Medicare and private insurance, but can you explain to me a little bit about the process, getting the authorization, how the reimbursement works, stuff like that, and tell the audience, can you do that for me?
So, Brian, I think all of us hate doing the peer reviews, right? Peer to peer. And sometimes you don't even get a peer, but that's a whole nother story. But,
No hablo, mi amiga. Yo no hablo.
We really haven't had a problem. And the hospital has backed this program that we're able to turn around reimbursement pretty quickly, you know, for these. So it has not been a big problem at all. And obviously the patients on clinical trial have a different set of billing regimen, but we have not had a problem getting these reimbursed or reimbursed for our time. I'd say the most difficult part of as a radiation oncologist is you never know when you'll be called to the OR. A case could take 3 to 4 hours, and in what time frame are you going to be called up? How's the resection going? Is it going quickly, slowly? Where are you? Yeah.
Has it increased your referral base?
I think it has with the advertising. I think it has. And it's interesting since we had the brain tumor center at one of the hospitals, and really the only hospital in the system that's offering GammaTile, we get patients from all over the greater Cincinnati area, and sometimes from Indiana, sometimes from Kentucky, but it has helped our referral base.
Betsy, I want you to do me a favor. Can you tell me some story about one of your patients and, you know, the outcome with GammaTile, and, you know, give me something positive, you know?
Okay, so I won't tell you, I have several good stories. One of my patients, I think I alluded to before, lives in the country, takes care of her debilitated husband, had a meningioma, resected several years ago, never got follow-up. And all of a sudden she was symptomatic, and she goes, I can't, after I have to resect this, I can't come in for 28 treatments, whatever we were going to offer her. And so we talked to her about the external beam versus GammaTile. She did GammaTile. She was home in 2 days. She's happy as a clam having someone drive her in for the rest of her scans. But my most recent patient, who I really think about, is, oh my gosh, she's only 54, a smoker, came into the hospital after being diagnosed with this musculoskeletal pain of the right chest wall for months and months and months, and came in with terrible headaches. And lo and behold, on CAT scan, had a fair-sized right upper lobe cancer and a solitary brain met. And what happened is, because we had the clinical trial and have the clinical trial available, we had her randomized through protocol for resection versus with GammaTile to follow, or resection and SRS. And she got randomized to the GammaTile. So we were able to get her in 5 days after her diagnosis, take out the tumor, GammaTile. I am now treating her, and we decided to treat her in a curative manner with only one metastasis. And we are now treating her with concurrent chemo and radiation therapy to the right upper lobe. And she's doing great with improvement in her chest wall symptoms. So yeah. I think at 54, that could be pretty exciting to get local control of both the primary and the brain disease.
Sometimes I think, you know, with these patients, it really pays to be aggressive. I mean,
I agree. Yeah.
They just surprise us in ways that you wouldn't. I think sometimes you do have to be aggressive, and, you know, there are some chances, and take them.
I totally agree. So I see her every week on her weekly visits, and the brain is like a non-issue. She said, that was the easiest. My esophagitis is bothering me, but my brain, no problems. You never have that.
My patients never have esophagitis, you know?
Good. And mine never have radiation necrosis either.
Hey, I got 2 more questions for you. You ready?
I'm ready.
Just so the audience knows, apparently we're both big football fans. And if we had a Super Bowl that had the Cincinnati Bengals against the Philadelphia Eagles. What do you think? Who would be the winner? What would the final score be?
Okay. The Bengals are going to be the winner because we're getting Joe Burrow out from his appendectomy. Okay. He just has to recover. But look at our receivers. Okay. Tyler Boyd. We have some really good players. Chase. We have some unbelievable receivers, and our offensive line is going to get better, FYI. But what would be the final score? Oh, we'd whip your tushes. I think it's going to have to be 33 to about 21 Bengals. And you, Brian, what do you think?
30 to 28 Eagles. I think the Eagles just have a running game. I think it's going to be fun to watch them. That line that they have is huge. I'm excited to see what the new receivers, how they do. I hope their defense is much better than last year. But I would see 30 to 28 Eagles. Let me say it the right way. 30 to 28 Eagles. You know,
and I'm going to say who day.
Last question for you. Ready?
I'm ready.
ACRO 2023 is going to be in Orlando, March, I think 13th to the 15th, if I believe it's correct. It is St. Patty's Day weekend since you're wearing green. It's also the first weekend of March Madness, and Orlando is a host site for the first round of March Madness. We going to see you in Orlando?
I hope so. Are we going to see you there too? Are we going to watch some basketball? Okay.
I'm always there.
Well, I'm a sports fan overall. I would love to go.
All right. I hope to see you in Orlando. Okay.
It would be really fun.
On that note, I just wanted to thank Fraser and everyone to listening today. I hope to see you all in Orlando in March in 2023. Stay safe.
Thanks, everyone. Thanks, Brian.
Take care, Betsy.
You too.